Hey, all of our lovely friends, lovely Omis, thank you so much for joining us today for our Eye on COOG webinar. If you guys are joining us from the online space anywhere around the world, really, please drop a hello in the chat. Tell us where you're from. Maybe tell us your diagnosis date if you feel like sharing kind of where you are in your journey. But we are thrilled to bring you guys Eye on COOG today. And we have about an hour and a half, max 2 hours, where we're going to be covering some really good content of what's new in the uveal melanoma risk reports. And this webinar is presented by Castle Biosciences and co-sponsored by IDEA, Immunocore, Aura Biosciences, and Delcath. So we can't thank our sponsors enough. Thanks for being here with us. In order of appearance, we have Dr. Amy Schefler, who's joining us, and we also have Dr. Basil Williams and Dr. Kat Alsina from Castle Biosciences. We're thrilled to have all of them here and thrilled to have this presentation. Up first, we're going to have our first segment covered by Dr. Schefler. Like I said, huge thanks to our sponsors. First up, speaker is from the Collaborative Ocular Oncology Group, and this is Dr. Amy Schefler. She's an ocular oncologist at the Retina Consultants of Texas, and I'm going to let her take it away.
All right, so thanks everyone for joining. Hopefully this will be super educational and helpful for everyone. I think the plan we're going to have here is I'm going to go over some background, and then we're going to take all the questions at the end. But my co-panelists here will monitor the chat, and if there's something urgent, they'll kind of nudge me, and I'll stop and answer any critical questions that we have. So thanks to Acure Insight, of course, for organizing this, and for Castle for asking Dr. Williams and me to join. It's an honor to be here with you guys. So I'm going to give everyone on the Zoom a little background about COOG and the history of COOG and kind of where we are with it today. So this is a photo of all of my friends. This is a picture of all of us at our collaborative meeting, actually in 2025. I think this is the 2025 picture in Dallas. We all get together once a year and talk about all the research that we're doing, the work that we've done already, the work that we are hoping to do in the future. Some of the definitely brightest minds in the uveal melanoma space are always at this meeting. It's one of my favorite meetings every year, and where we've hatched some of our very best ideas. And this meeting is coming up next month, so we're all looking forward to it. So just to give everyone a background on where this started and where we're going. Many folks around the country, researchers, had been looking at the genes involved in uveal melanoma ever since the early 1990s, actually. Cytogenetics, which is the study of looking at chromosomal breaks and missing pieces of chromosomes and abnormalities, started all the way back in the early 1990s. But it was a long time before people kind of realized, how researchers realized how could you take that information and sort of use it in a way that was valuable for a clinical setting. So it was kind of in the early 2000s that Bill Harbour, in his lab at Washington University in St. Louis, started looking at the expression of some of the really important genes involved in this tumor, and kind of looking at whole genome sequencing, looking at all the genes in the human genome and saying, hey, which of these are really critically involved in this particular tumor? And eventually they honed in on 12 particular genes, which seemed to be especially important in terms of whether they were overexpressed or underexpressed meaningfully in this tumor. And over time and over years of hard work, kind of put together this panel of 12 critical genes that seemed to kind of define which of these tumors were really aggressive and which were not so aggressive. So in order to kind of verify those findings, the COOG-1 study launched in the mid-2000s to try to look at this panel and see if it was really predictive of how aggressive these uveal melanomas were. And that study was published and led to the kind of CLIA approval, the lab certification of the testing, and the widespread use of it clinically. And so it's a 15 gene signature test, 12 what are called experimental genes, meaning the genes that are important, and 3 control genes. And that test is now, ordered, as everyone knows, clinically through Castle Biosciences, and the brand name is the DecisionDx-UM test. And, has been widely used throughout the United States and other parts of the world since then. And then as the use of that test picked up and evolved, many investigators published their clinical experience with it. And then over time, other genes were discovered to kind of be independently important. In 2009, 2010, a couple of groups around the country found that a gene called BAP1 was particularly aggressive and involved in when it was mutated, when it was kind of misprinted in the human genome, leading to a particularly aggressive form of this disease, and other genetic mutations also were learned to be important as well. In 2016 was the first publication about what's called PRAME, or preferentially expressed antigen in melanoma, which is a tumor antigen that is normally only expressed in healthy tissues, believe it or not, in the testis and the ovary and sometimes the endometrium. But when it's abnormally expressed is a marker of also tumor aggression, both in uveal melanoma and other tumors. So that kind of became part of our algorithm. And then finally, all the way to the current day, in 2017, we launched kind of the second phase of this study, which was finally just published this year. So as many on the Zoom know, this is kind of the clinically sort of the approach that we take now as ocular oncologists. We see patients in the clinic and we identify that they have a uveal melanoma. We speak with the patient, counsel them, explain to them that we're planning on doing treatment, which most of the time in the United States involves either plaque brachytherapy or external beam therapy or nucleation. At the time of that therapy, whatever we choose, we do a biopsy, all wrapped up into that same surgery, in which we send the specimen for all of these tests that I just mentioned. And then typically, anywhere from 2 to 4 weeks later, we get that information back from Castle and counsel the patient with that information. There have been other approaches that have been taken by some investigators to try to kind of have clinical surrogates for this, like can we just look at the tumor size? You use AJCC staging. But the challenge with a lot of those other systems is that there are often outliers, and we're going to show you some examples of this later in the Zoom. So some patients with really big tumors will actually have very non-aggressive biology, and some patients with very small tumors will actually have very aggressive biology. So it's important to look at the genes in the tumor because that's what really drives our understanding. So with this biopsy that we do intraoperatively, we get information from these 3 key tests. So the 15 gene expression profiling, which I mentioned, which is our strongest and most powerful and most predictive test that we've had for the longest, that's been the most proven in the most prospective studies, kind of the gold standard in science. Then we get results from our PRAME expression test, the antigen that I mentioned, and the readout from Castle will state that that's either positive or negative. If it's positive, it means that that antigen is being expressed by the tumor cells in that particular patient's test and are a sign of more aggressive behavior. And then what we call the next generation sequencing test, which helps us look at particular mutations in the tumor. We'll talk about that more in a second. So this is an outline of those 3 tests. Each patient will get a readout that says basically that their tumor is either low risk class 1 or high risk class 2. And again, what this riskiness is the riskiness or likelihood that that tumor may or may not have gotten out of the eye before the time of diagnosis of the tumor, but to have a situation where there are too few cells to see on the imaging test that has often been obtained before the treatment of the liver. So for example, if 1 or 2 or 3 cells have gotten out, those cells won't be visible on the MRI or the CT scan because we really need 750,000 cells or a million cells to make it visible on the MRI. But there might be 1 or 2 or 3. And if the tumor is designated as class 2, we know, okay, there's a chance we might be in that situation. And then the PRAME also helps us understand what's the likelihood that may have happened as well. And then we look at these mutations. So there are 7 mutations on the readout from the report from Castle. These first 4 here that say uveal melanocytic driver mutations are actually what are called initiating mutations. So those are mutations that help us understand that in fact our biopsy did come from a melanocytic lesion, that it came from a uveal tumor of melanocytic origin, and it helps us know that in fact this tumor specimen was of good quality and from the correct tissue type, so that we didn't send retina or vitreous or normal choroid, but that in fact we did send cells from that patient's tumor. And then these other 3 mutations here, EIF1AX, SF3B1, and BAP1, help us understand also the level of riskiness of that the tumor may have metastasized prior to the time of doing the treatment. So EIF1AX is associated with a low mutation, low risk of metastatic disease, so more associated with class 1. SF3B1 is an intermediate mutation, and BAP1 is a very high risk mutation, in most cases associated with a class 2 genotype. So this is the data from the COOG-1 study, that very first study that kind of established this test as clinically valid and scientifically valid. And essentially what this diagram shows is that patients with class 1, in the overwhelming likelihood of cases, survive and go on to live many years without metastatic disease, whereas patients with class 2 are more likely to develop metastatic disease over time. Now, this is just an algorithm, a statistical algorithm. So it's not that every single class 1 patient lives forever or every single class 2 patient dies of metastatic disease, but more a statistical likelihood that we use to counsel patients. And many, many investigators, as I mentioned, have published their data and their experience with these tests ever since the time of their development in the lab, showing that it's, both clinically and scientifically valid. The COOG-1 study, all the way back in the mid 2000s, all the way to the COOG-2 study at the current day. So how do we kind of interpret these biomarkers and counsel patients? We're going to kind of give you some examples of cases at the end that I think will help give more color as to how we do this. But as time evolves and these tests become more and more used on a very large scale clinically, we've become more and more savvy at how to kind of integrate the information from all three of these tests and kind of make it useful for patients. And we'll illustrate that again in a little bit. So all of this work has really been very collaborative, and it's important with rare diseases like this to kind of leverage the intelligence and clinical experience and scientific work of everyone across the country who's dedicated to patients with these diseases. And this is the group of COOG-2 investigators across the country. I'm sure many of the patients on the Zoom know these folks and have had many intimate interactions with them, being taken care of by all these amazing clinicians. And these are all people that Dr. Williams and I call colleagues and friends every day. So these are the investigators who contributed patients to the COOG-2 study and contributed intellectually to the understanding and scientific advancement of what we learned from the study. So there were 26 centers in the study all across the United States and Canada. We had many, many, many Zooms on Saturday mornings, early in the morning, on our executive committee, discussing all of our data and coming to understand it and analyzing it and so forth. It was hundreds and hundreds and hundreds of hours of work on behalf of our patients. So there have been 2 studies published so far from this data set, both this last year and this year. It's too kind of scientifically dense to get into all of the details, but essentially the first report revalidated the value of PRAME in understanding the level of aggression of these tumors and started to dive into the use of next generation sequencing. And the second report, which is literally like in the process of being published right now, or coming out right now, talks about the value of next generation sequencing. And there'll be many, many, many more papers from this massive data set of over 1,500 patients coming out over the next year or two, which will slowly kind of leak out into our like everyday clinical experience and what we're able to counsel patients with day to day. So many, many years of experience have gone into making this data useful for patients. So I'm going to turn it over to Kat Alsina from Castle, who's going to kind of take it from here and talk about these reports that we give our patients and kind of how we use them day to day and the new version of this that has come out as a result of the COOG-2 study, and kind of understanding that report that your doctor has given you.
All right. Well, thank you, Dr. Schefler. That was a beautiful overview of the history of COOG and gave us a good high-level sense of what the first 2 studies have covered. I'm going to focus in now about how some of the results from the first COOG-2 report are being integrated into Castle's clinical reporting and into national guidelines for managing patients. As Dr. Schefler discussed, the COOG-2 study is really the largest and most comprehensive study to date that has looked at Castle's 3 tests for uveal melanoma. And the first report that Dr. Schefler mentioned focused on PRAME and what PRAME adds to the information from the 15-GEP test. Castle's PRAME test has been available since 2016, and the COOG-2 study cohort included over 1,500 patients that were tested with both the GEP test and the PRAME test. So that's a really large cohort of patients for such a rare disease. It's an incredible collaborative effort to get those patients enrolled into the study. But the most important finding from that study gives us really the first strong data around PRAME's contribution to metastatic risk. And I'm going to show some of the data in just a second. But really, the study found that PRAME works to kind of fine-tune risk for both class 1 and class 2 tumors. But before I go into the data, I thought I'd start with a little more background about PRAME. Dr. Schefler already kind of covered some of this, but PRAME stands for preferentially expressed antigen in melanoma. It's a gene that is usually not found in many normal adult tissues, but in some cancers like uveal melanoma, PRAME levels are abnormally elevated. So when PRAME gets turned on in uveal melanoma, that might indicate a higher chance of an aggressive tumor that's more likely to spread. And so back in 2016, there was a lot of interest around PRAME because of some early studies from Dr. Harber's lab that suggested that, increased expression of PRAME was associated with more aggressive uveal melanomas. And so, specifically, this seemed to have more of an impact in the class 1 tumors, with class 1 PRAME positive tumors being more risky than class 1 PRAME negative tumors. But anyway, in 2016, Castle started offering this PRAME test based on those early retrospective studies. But the COOG-2 study is really the first prospective, so forward-looking study to evaluate PRAME in a large group of patients. So this is what the main data looks like from that first COOG-2 study on PRAME. So the left is a graph of metastasis-free survival, where you can see there's a separation of 4 distinct groups. The top 2 lines there are class 1 tumors, which separated depending on whether they were PRAME negative, so that's the dark blue line at the top, or whether they were PRAME positive, which is the teal line right underneath it. And then similarly, the bottom 2 lines are the class 2 tumors. So you can see that those class 2 tumors also separated out into 2 distinct groups, depending on whether they were PRAME negative, so that's the orange line, or PRAME positive, and that's the red line. So essentially, both class 1 and class 2 tumors were stratified depending on whether they were PRAME negative or PRAME positive. And so that was an important finding, that PRAME status is able to modify the GEP risk result. And so on the right, you can see a summary of what that new data tells us and what it means for patients. The class 1 PRAME negative tumors have the lowest risk of metastasis at 5 years. And in the COOG-2 study, about 96% of patients were metastasis free in that group at 5 years. The class 1 PRAME negative tumors have an intermediate risk of metastasis, with 81% of those patients metastasis free at 5 years. And then the class 2 tumors remain the high risk group, regardless of PRAME status. But there is a meaningful difference between class 2 tumors that are PRAME negative and class 2 tumors that are PRAME positive. So the class 2 PRAME negative tumors do better, with 58% metastasis free at 5 years, compared to 45% metastasis free in the class 2 PRAME positive group. So these findings were hugely important to us here at Castle. And based on those findings, we felt pretty confident that it was time to update our reporting. So earlier this year, we rolled out updates to both our GEP test report and our PRAME test report. Those 2 results are still reported separately, but we have updated them to include the new risk data from the COOG-2 study. And so the most important data is going to be found on the PRAME report, which is shown on the right, it highlighted in orange. And that's where we've included the risk estimates that are associated with the combined groups. So the GEP and PRAME, when put together, gives you those 4 different groups with specific risk estimates. The other really exciting update in 2025 was a recent change to the uveal melanoma guidelines. And so the guidelines are updated whenever new and important data is published that is considered to be practice-changing data. So after the PRAME findings were published, the Uveal Melanoma Guidelines Committee reviewed that data and updated their management recommendations for patients. So the guidelines now recommend using PRAME status alongside the GEP class results to help better tailor surveillance plans for patients. And so this slide just kind of summarizes what that management pathway looks like now when incorporating both the GEP class and PRAME status together. And so you can see, different surveillance plans are recommended now based on those combined results, with the class 1 PRAME negative tumors following the lowest intensity management plan with image-based surveillance every 12 months, and the class 1 PRAME positive patients, which is this intermediate risk group, following slightly higher intensity surveillance plan with imaging every 6 to 12 months, and then the higher risk class 2 patients following the highest intensity management with surveillance every 3 to 6 months, and they may have the opportunity to enter adjuvant clinical trials to try and prevent or delay the onset of metastatic disease. So these were really exciting updates that happened over the past year. And I think particularly these changes to the guidelines really represent a huge step forward in personalizing care based on each patient's unique tumor biology. So with that, I'm going to turn it over to Dr. Williams, who's going to talk about the second COOG report that focused on the value of DNA mutations.
Thanks so much. There have been two fantastic presentations so far. Thanks to Danet from Ocular and Kat Alsina from Castle Biosciences. I'm excited to be here with you today. And we've had two fantastic talks already. And I'm going to be talking a little bit about the role of DNA mutations and mutation sequencing and the information beyond GEP and PRAME. And so, Dr. Schefler did a fantastic job kind of highlighting the Decision DX testing for GEP and for PRAME, and Kat Alsina just talked about that a little bit more. And I'm going to be focusing a little bit more on Decision DX-Seq. And this is a custom DNA sequencing test that looks at the most commonly associated genes with uveal melanoma. And we know that uveal melanoma has a lower number of mutations than other cancers. And this is kind of one of the reasons why it may be more difficult to treat than other types of conditions, including skin melanoma. And so you can see some of these mutations here, and we'll go into a little bit more detail about them. So what do these mutations tell us? We wanted to kind of understand what does the role that these mutations play in our understanding of uveal melanoma, in our understanding of prognostication, basically meaning the risk of metastatic disease developing in the future. And so this was studied in the COOG-2 study group, and there were over 1,100 patients evaluated for these mutations. And here you can see the report that looked at these DNA mutations. And this is the preprint version that's available, and it's going through some final peer review, but should be expected to be published completely in the very near future. And kind of before I go into some of the discussion on that paper, we'll give you a little schematic so you can understand the role of these mutations in melanoma. And I'm really happy that I went after Kat Alsina because I only had the 8-pack of crayons growing up, and so I wasn't quite sure what color the SF3B1 mutation was, and now I know it's teal, so that's helpful for me. So basically what you can see here is that there is kind of an order to these 7 mutations. And so you start out with a normal melanocyte all the way on the left. So this is a cell that everyone has. And then it can develop one of these 4 mutations in orange. And when you develop one of these mutations, it turns, the melanocyte can turn into a nevus. And so that basically is like a mole. At that point, that's still a benign lesion, and then it can undergo a second set of mutations, either an EIF1AX in blue, an SF3B1 in teal, or a BAT1 mutation in red, and that's what turns it into a malignant melanoma and gives it the possibility of developing metastasis. And so, you can see here that the mutations in orange, they're found in almost all of the tumors, but they don't give us prognostic information. So they do not help us identify or differentiate which tumors are more likely to spread to other parts of the body. But it is really helpful for us to understand that this is melanocytic tumor conformation. Basically, that when you've done your biopsy, you have tumor material. And this is something that is extremely helpful for physicians and patients alike to make sure that the biopsy sample was from the tissue that you wanted to test. And then you have your second set of mutations that we mentioned, and these are found in about 60% of tumors. And EIF1AX and SF3B1 are most likely found in class 1 tumors, and they're associated with a lower risk of metastasis, whereas the BAT1 mutation is more commonly found in class 2 tumors, and obviously therefore has a higher risk of metastasis. But when we look at this, does this provide any additional information to what we found with GEP and PRAME? And it turns out it does not add additional risk information to GEP and PRAME. And so basically what that means is we're able to focus on the class and PRAME status, and that will give us the most information that we need to determine what the risk is of metastatic disease in the future. Does that mean that these mutations are not helpful? No, they are helpful. They actually do provide information for us. And what kind of information do they provide? So we know they're not as accurate as GEP or PRAME for risk assessment, but it does help us to understand our tumor sampling confirmation, which we talked about, making sure that you have tumor sample there. We also know there's diagnostic confirmation. So if you have a mutation, one of the orange mutations, a G protein mutation in the beginning, we know it's a melanocytic tumor. So it is along the lines of a nevus at the very least. When you have a second set of mutations there, we know it's a melanoma. And so that can be helpful to confirm the diagnosis. We can also get some early information about germline or inherited mutations. Dr. Schefler and the team from Castle Biosciences helped to put together a little study looking at patients who have a BAP1 mutation and then being able to test those to see if they have a germline or an inherited mutation, which makes them more likely to develop uveal melanoma and potentially other cancers. So this is something that's helpful in that. It is also, these mutations are also helpful in terms of qualifying patients for clinical trials, so we can understand which patients have higher risk and can benefit from some of the clinical trials that we have going on now. We also know that a number of patients have asked, well, if I get a biopsy, what are the chances that we actually get sufficient information, that we get enough information from the tumor to be able to kind of gain information about prognosis? And you can see here that the results from the biopsy of all three of these samples, of all three of these tests taken together, are extremely high. And so this is not just from the COOG test, this is actually from Castle's database. And you can see over 3,700 patients are assessed. And when we're looking at GEP testing for class 1 and class 2, you can see that there was 97% of those lesions had a successful report. For PRAME, it was 99% had a successful report. And when you're looking at the DNA mutations and the next generation sequencing panel tests, you can see 97% of successful reports. And so basically it means that when you get the biopsy done and it is sent out for analysis, you're getting an extremely high rate of sufficient material and successful reports. So this is good news for when the biopsy is done. And so basically, it's extremely unlikely that if you get testing, you will not have a result because there's insufficient information. And so at this point, I will kind of turn it over to the group a little bit, and we'll go over some case examples and have a panel discussion, and then kind of go through some of the Q&A. And so I think, you know, our first case here is a case of Dr. Scheffler's, and I can have her take it away.
Thanks, Dr. Williams. Great job reviewing next generation sequencing. All right, so we thought we would share some cases of patients with you all to kind of help understand kind of day to day how we as clinicians use this information to help us counsel our patients. Some of this is kind of scientifically nitty gritty, and hopefully some of it will feel pretty accessible. And of course, feel free to ask any questions in the chat as we go along. So this is a patient of mine who's a 63-year-old gentleman who came to me about almost 5 years ago with a large uveal melanoma that would be considered very aggressive based on traditional staging methods based only on size. This is a fundus photograph, so a photograph of the back of his eye. And actually there's a little bit of an error in this slide. This is actually not the photograph of what he looked like when he first came to me. But when he first came, the tumor was actually obscuring a view of his entire optic nerve and his macula completely. And this ultrasound is the correct ultrasound of the eye when he presented. So this is what we call collar button shaped melanoma. It has kind of a big mushroom shaped head with a kind of a skinnier neck. And you can see that the dark area here at the base of the tumor, this area is sort of darker than the apex of the tumor, which is typical and classic for uveal melanoma. So we took this patient to the operating room. We performed the plaque radiotherapy that we do. We did the biopsy of his tumor, and it came back actually with amazingly very low risk genetics. So class 1, PRAME negative, and as we just talked about, those are our markers for low risk for metastatic susceptibility. And on our next generation sequencing testing, the patient had both a GNA11 mutation and an EIF1AX mutation. So what that tells us is that, okay, we've got an initiating mutation GNA11. We know that our sampling was of good quality from a melanocytic tumor, and we know that it's got, low risk changes in its DNA. So everything in this patient's testing points to the concept that his disease is ironically not that aggressive, even though it grew to quite a large size in the eye. And so here we are nearly 5 years later, and this photo on the left is actually what his eye looks like now. Now we have a full view of his optic nerve and his macula. His tumor regressed from covering the entire center of his fundus to kind of regressing to the infranasal corner here. He's alive and well. His vision actually improved after the treatment, which is very unusual with a tumor this large. And he's doing great and feeling very good about his prognosis and his long-term outlook. And I think he actually may even be on the Zoom. Feel free to speak up if you'd like. So this is the situation where, we can kind of illustrate here that, the devil's really in the details of the genetics for these patients, not so much, in the size of the tumor. There are real outliers. If we just had told this patient, hey, you have a huge tumor, you're definitely going to die of this disease, that actually would have been very false information. And so, as I mentioned earlier, there are outliers on both ends of the spectrum. There are patients who, oh, there he is. He decided to go public. My patient, John Reese, just commented on the chat that he's here. So now he's famous. So I think the important point here for patients is that this testing is really critical because, the way we practiced in the 80s and the 90s and the early 2000s, in which we told patients, hey, you have a big tumor, it's going to be terrible, or hey, you have a tiny tumor, you're definitely going to be fine. Those are really outdated ways of practicing medicine these days. The idea here is that we have, very personalized genetic medicine here where every patient's treatment is really tailored to them based on the true molecular genetics and their own personal tumor. So this is kind of a nice example of that.
Excellent.
Okay.
Thanks for sharing that example, and we'll go on to your second case.
All right. So this is a 48-year-old gentleman who I was just trying to think if this patient is on the chat. I'm not sure. Who is a patient of mine who presented with a more of a classically medium-sized tumor, which is kind of the size that most patients in the United States and the developing world present to us in. His tumor was 15 millimeters in base and 7.9 in height, kind of, I would say, the upper end of sort of the medium-sized category. And his genetic testing came back after his biopsy and his treatment, unfortunately, with very aggressive genetics, class 2, PRAME positive, again, with the GNA11 mutation indicating that, our tumor sampling is from, good quality specimen with a BAP1 mutation, which also demonstrates that on the DNA level, his tumor risk is quite high, and that kind of matches up also with his GEP class 2 genotype. So in every way, a very aggressive tumor genetically. So we said to this patient, as we do to all of our patients with a profile like this, okay, we're really worried about that one or two or three of these cells might have escaped and gotten out into your systemic circulation before we met you. So we're going to survey your liver, quite often and see if something popped up there. The frequency at which patients like this are followed with imaging and what imaging they get is quite controversial, and I think kind of too extensive to talk about on this Zoom. But suffice it to say that in our practice, we follow patients like this with MRI surveillance every 3 to 4 months in the beginning. And so this patient underwent very close surveillance. He had a very small metastatic focus that was detected early. He underwent a biopsy of that lesion in his liver to confirm that, in fact, it was metastatic uveal melanoma, and was started very early on tebentafusp, which is one of our 2 FDA-approved medications for patients with metastatic uveal melanoma. And he is currently doing well on that therapy 3 years, almost 4 years post diagnosis. And probably in part, he's doing well because his metastatic disease was picked up so early. So this case kind of illustrates the other thing that Dr. Williams mentioned, which is that the other usefulness of this testing is so that we can identify those patients who are at very high risk of developing metastatic disease and get them into very close surveillance. And then after surveillance, if and when metastatic disease is identified, get them on treatment or get them into clinical trials as soon as possible. And then we study those patients, of course, over many, many years as well to see, what are treatments for metastatic disease, what kind of effect that has on patients, and whether it makes a difference to start that treatment early. So particularly for a patient as young as this patient. He's a 48-year-old gentleman. He's quite young. He has children. We really want to try to be as aggressive as we can in every way. And one way that we can be aggressive like that is to know, okay, this is a patient who we need to survey very frequently and very early.
Excellent. So thanks for those two wonderful cases. I'm going to share a case here as well. And I think Dr. Schefler did a fantastic job of highlighting the importance of GP and PRAME. And my case is going to show a little bit about the importance of the DNA mutations and next generation sequencing. So this is a patient that came in, a woman in her 60s, and she actually had a huge amount of inflammation around the eye, and her eye was in pain. She got orbital imaging, and it showed that there was a tumor that was partially inside the eye and partially outside the eye. And she was given steroids on the outside that decreased some of the inflammation. And then she came in to see us. And when we saw her, we could see the lesion here, a pigmented lesion consistent with a uveal melanoma, but she had a very large component outside of the eye. Based on this, we were planning on doing enucleation or eye removal, and we were having a discussion about whether or not there would be any benefit to doing radiation after this. The patient wanted to discuss this with radiation oncology, and actually, when she talked to them, they weren't sure that this was a melanoma because the lesion had actually shrunk in size after she was given steroids. And so, as a result of that, radiation oncology wasn't fully on board with us proceeding with enucleation because they thought if this was a different type of tumor, they wouldn't want us removing the eye unless the diagnosis was correct. And so, we obviously agreed that it wouldn't be appropriate to remove the eye in the wrong diagnosis, and we ended up doing a needle biopsy of this lesion. It turns out this lesion had a large amount of necrosis, basically meaning the tumor had outgrown its blood supply a little bit. And so when we looked at the cells were a little bit difficult to assess and to confirm the diagnosis. However, we were able to look at the DNA mutations and see that there was a GNA11 mutation, which is one of the orange mutations that we talked about in the beginning, showing that this is a melanocytic lesion. And it also had an SF3B1 mutation, which is the second type of mutation that was in teal, and that helps confirm that this was in fact a uveal melanoma. The patient was then treated with enucleation, and pathology supported the diagnosis that this was a melanoma. And this was a very helpful thing in this scenario because we were able to proceed with the appropriate treatment in a timely fashion, as opposed to there being some debate about what was the correct diagnosis and then potentially delaying the appropriate treatment. And so, as we kind of mentioned, looking at DNA sequencing can really help us confirm, number one, that the tissue that we sampled was the tumor, and it can help confirm that the tumor was, in fact, a melanoma. And this patient is alive and doing quite well. And so we have one last case example here as well.
Okay, great. All right, so this is another patient of mine, and this case we're going to use to illustrate the usefulness of next generation sequencing, which is, the third test that we mentioned among the suite of tests that are offered by Castle. So it's our newest test and our test with kind of our least mature data, but it's turned out to be very useful as an adjunct. So this is a older lady in her 80s who I saw, I think, close to a year ago now, who presented with a kind of a more unusual presentation in which she had a kind of salmon-colored lesion here underneath her conjunctiva. Oh, you guys can't see my mouse, but this kind of pinkish lesion, yeah, perfect, underneath the conjunctiva, as well as another lesion at 12 o'clock, whoever's got the mouse, thank you, Dr. Williams, in her interchamber, so the front of the eye right there, arising from her ciliary body and kind of extending into her iris, that kind of pinkish whitish area. That's right. And on the ultrasound, what's called the UBM, or the ultrasound of the front of the eye, you can kind of see that tumor right there. It's kind of nudged up against the cornea and crowding out the front of the eye. So she had two different lesions that were non-contiguous, not touching each other in the front of the eye, and particularly that salmon-colored lesion on the surface of the eye was pretty atypical for this disease. And so what we did was we did a biopsy, just as Dr. Williams did in his case, more from a diagnostic standpoint, like, okay, what are we dealing with here? And we found that the tumor had a GNAQ mutation, so a initiating mutation as well as a BAP1 mutation, suggesting that it was quite an aggressive melanoma, and actually suggesting that the tumor had actually started at that 12 o'clock position in the cellular body and then spread around what we call the anterior chamber angle and then extended extraocularly out of the eye into that space externally. You can see her GP came back class 2 and PRAME positive, also confirming that she was at a very high risk of having metastatic disease, although her imaging of her liver at that time was clean. We performed a enucleation, and she's still alive and well about a year later. But this is a situation where, the next generation sequencing was really what helped us understand, okay, in fact, this is a melanocytic tumor. This is a uveal melanoma. It's not another one of the cancers we might think could present in this type of unusual way. I will add that in our center and for Dr. Williams as well, and in most centers, who treat a lot of patients with this disease, we typically do not use these tests for diagnostic purposes. It's really up to the clinician to be able to examine the patient and be sure what the diagnosis is, just on the basis of clinical skills and diagnostic testing. But there are these outlier patients like this one of mine who, where you really need it. So it really shouldn't be a situation where every single patient who's seeing the clinician is needing this test to prove what the diagnosis is. But when there are outliers who have unusual findings, next generation sequencing can be quite useful for that purpose. So this was kind of a good case to illustrate that.
Excellent job. This is the last case that we had.
Okay, so this is a 70-year-old patient of mine who also presented with a kind of medium large tumor that we can see here in his left eye on the nasal side. So the side closer to the nose, and it's kind of overhanging the optic nerve. Here's the optic nerve, here's the macula. These are the blood vessels here. And then we can see on our ultrasound, here's the front of the eye, here's the back of the eye. Oh, sorry, you guys aren't seeing my mouse. Thank you, Basil. And then, we can see our tumor there. That's sort of a very classic looking ultrasound for a uveal melanoma. And so it's quite a large tumor. So this patient underwent treatment with a biopsy, and his tumor profiling showed, quite high risk genetics. He was class 2. He was PRAME negative, but he was class 2, so certainly a high risk patient. And he had both a GNA11 mutation, so initiating mutation, and a BAP1 mutation. So as a result of the fact that this patient had a BAP1 mutation in his tumor, we thought to ourselves, okay, this is a patient who, has a BAP1 mutation. Is it possible that he also has a hereditary BAP1 mutation, meaning that he's got this misprint in his DNA and all of the cells of his body that he was born with this mutation. And that was in fact what put him at risk for developing uveal melanoma. When we had elicited his family history, he had actually several family members who had had various unusual cancers, which sort of tipped us off to that. And so we thought, okay, we need to test this patient for a germline BAP1 mutation, which is a blood test, in which a company that we work with in California looks at the leukocytes in the patient's bloodstream and says, the white blood cells, and says, okay, does this patient actually in fact carry this mutation in all of his cells? And in fact, that test came back positive, matched to the mutation that Castle had identified in his tumor. And that helps us understand, okay, this patient carries what's called BAP1 TPDS, or tumor predisposition syndrome. And he was not only at risk for this uveal melanoma, which we didn't know in advance, but in fact for other unusual cancers as well, which we now need to screen him for, and also led to what's called cascade testing, in which we tested various family members of his for this tumor, for this syndrome, and now know that those family members are at risk for these other rare cancers. And screening for those cancers can make a major impact on those patients' prognosis and survival from not only uveal melanoma, but other tumors. So this is a situation where we can, in fact, do quite aggressive preventative medicine, not only for the patient, but for his family members as well. This patient's brother had died of an unusual tumor called mesothelioma, which is a cancer of the lining of the lung, which is very heavily associated with this syndrome. His brother had also had another cancer. His nephew had also had a cancer at a young age. So it was, kind of a widespread family history that kind of tipped us off that we really need to sequence this patient for this syndrome. We have actually, Eve has actually developed a protocol in our center in which we actually test all patients who have a BAP1 mutation in their tumor for the inherited form of this disease to make absolutely sure that we have not missed a single patient. And we have a research paper that'll be published shortly kind of talking about these results that we've developed in our center. But irrespective, the point being here that these mutations will actually sometimes tip us off to an even bigger implication of these findings, not only for the patient, but for their family members. So that's why these tests are very important.
Yeah, Dr. Scheffler, this is a really important case, and this is something that you presented recently. I saw your presentation on this, and I thought it was really powerful because a lot of times when we're thinking about an inherited BAP1 mutation, we're thinking about patients who are younger or who have a very large family history of different types of cancers, which this patient did. But I think this is really helpful to understand that if a BAP1 mutation is there, it's worth considering at least looking for an inherited BAP1 mutation, not only for the patient and screening, but for family members, for potentially for children, et cetera, to be able to assess their risk of both uveal melanoma and other cancers moving forward. So this is a particularly helpful case example.
Awesome. Thank you so much, Dr. Williams, Dr. Scheffler, and Kat. We are so grateful for all of this information, and I know we've had a good number of questions coming through the Q&A. Kat, can I have you take the first question, the one from Amanda? Essentially, she says she lives in Costa Rica, so out of the United States, and had her eye enucleated. Wasn't offered any genetic testing, but she was able to get pathology slides and the cross sections of the tumor preserved in paraffin wax. Is it possible to have any genetic testing done from tissue preserved in the wax?
So yes, all of our tests are validated for both fresh tissue and fixed tissue. If the eye was removed, enucleated, and put in formalin to fix it, and then in wax to preserve it and be able to section it, we can test that. The one kind of nuance there is that it does need to be from an enucleation. So we've tried testing other types of fixed tissue, like fixed cells. Dr. Scheffler knows this, and it just hasn't worked out because there's not enough cell quantity there for us to test. But if it was an enucleated eye that was fixed, we can test that.
So, Kat, address the kind of subtlety of the question, I think, that this patient asked, which is a good one, which is, can the center where those slides are present, did they just send the slides directly to you all? And then in-house, you're dissecting that tumor off the slides?
Yes, so the pathologist would need to initiate the order, and they can either send us the full block of tissue and we can section it in-house to get what we need and send the rest back, or they can send us slides that are already cut. It sounds like in this case, there are already sections cut up and put on slides. So if they want to send those to us, they can do it that way.
Perfect.
But our team would reach out to the pathology lab once we receive the order to get all of those logistics worked out.
And I feel like, Kat, a good follow-up question to this might be, just for anybody who is outside of the country, is having the DecisionX test done on an upcoming tumor biopsy for a treatment. So say they're scheduled for plaque, they're going to be treated, I don't know, somewhere in Europe. I'm just picking a random location, but is it possible for them to request the biopsy before this treatment even happens, even if it's just for plaque, not necessarily an enucleated eye?
We do have the ability to test samples from outside of the US. We regularly test cases from Canada, from Western Canada, from parts of South America. We're starting to see more and more samples coming in from places in Latin America. There are some hurdles that we have to overcome with customs. So every country has, different regulations around sending fresh tissue specimens overseas. So those are things that we need to work through. But yes, we're able to test specimens from anywhere in the world as long as they can get to our lab.
What I would say, kind of as a corollary to that, is that if you are a patient who is abroad outside the US and going to undergo treatment and you haven't worked out those details yet, the most important thing is to ask the clinician to do the biopsy at that time, because you can't go back and do it later, and bank the tissue. And I'm sure, people can reach out to the folks in the lab at Castle and kind of get the information about exactly how to store it properly. And then, while those issues, shipping, customs, funding are worked out, so that at least the tissue is banked and being held properly and then could be sent later. So if the tissue is banked appropriately, it could be sent a year or two or even more later, but you have to get it at that time. So that's kind of the critical decision making before the surgery.
Okay, wonderful. So our next question that came in was from Roger, and he asked about a test that was done in 2012, and there was a result on the Castle test, a 1B result, and there was no PRAME listed at the time because that test wasn't available. Is it possible to, and there's also no remaining biopsy material, is it possible to find any PRAME information at this point? Why or why not?
Depending on when the biopsy is done, there may be some residual tissue material. In your specific situation, you noted that there's not any residual material left. And in that situation, unfortunately, we are not able to obtain additional information on PRAME or any of the next generation sequencing tests looking at DNA mutations. In your situation, we won't be able to assess that. If biopsies were done more recently, you can check and see if there are any residual samples, and sometimes those tests can be run if they were not run originally. But that's something that needs to be checked on a case-by-case basis.
For anyone who was tested with the GEP after mid-2015 or so, and if you didn't have PRAME or mutational sequencing done, at that point in time, we started storing residual specimen. So we may have some residual tissue remaining that we could use to run PRAME and sequencing, but it would be, post 2016, 2015, 2016 timeframe.
The history of that actually is that I had some situations in 2015 and 2016 in which I had patients asking exactly the questions that you all are asking, where they wanted to go back and get that type of information. And I was pretty needy with Castle that I wanted to start a program where we were able to bank tissue exactly for that situation. And because I anticipated we would have a lot of, new developments over the years of other testing that would be useful for patients. And I wanted to kind of prevent that situation to the future. So one thing I would recommend that you all talk to friends about who are being newly diagnosed with this disease is asking the surgeon who's taking care of the patient to try to utilize that program that Castle offers and bank tissue with each procedure, so that let's say 10 years from now we're not in that situation, right? So every patient has bank tissue that can be used down the road, because you can't bank it later, you have to bank it in advance.
So this may be kind of a no-brainer question, but I guess maybe let's just answer it just because I think it's worth answering, and it comes up a lot every time we talk about the biopsy. Why do you have to have the biopsy done before the lesion is treated? What does that affect? The treatment itself.
Sure, I can answer that. So basically, we have studied the COOG group have studied prospectively the biopsy results from before radiation treatment. We have not prospectively studied what the results are after radiation treatment, and so we do not know if radiation treatment is going to affect the results of the biopsy, and so we cannot stand by the accuracy or validity of any information that comes out after treatment happens. This is the reason we want to make sure, from a quality control perspective, that the way things have been studied and been proven to be accurate are the ways that the test is run for you.
One way to think about what Dr. Williams said is that if your surgeon has performed a plaque or protons on your eye, and the whole purpose of that treatment is to completely kill all the DNA in those cells so that they can no longer grow and get out of the eye, then that DNA is not of normal quality anymore, which is exactly what you want. And therefore, you cannot assess its level of expression of different genes. It's dead. So that's kind of the way for patients that I always explain that to patients. We don't actually want that DNA to be active and expressing the genes it did before it was treated, right? So it's now crappy tissue. It's basically a big fat scar, and we're not going to go back in there and try to understand its biology anymore because it's not active the way it was prior to treatment.
Okay, so this next question is talking about isodisomy 3. Is that a test marker that is equivalent to the BAP1 and the class 2?
So maybe just for some background, I mentioned, I think, when I was talking about cytogenetics is the study of kind of looking at an array of chromosomes. So, we all have a certain number of chromosomes that we're born with, and there are actually ways to kind of take those chromosomes and sort of lay them out almost on like a visual diagram and see them. And sometimes some patients, either from inborn errors or from things that happen later in life, will actually be missing a piece of a chromosome, of a particular chromosome, a part of it, or even a whole chromosome, or chromosomes can be duplicated and so forth. So it was discovered in the early 1990s that chromosome 3 was really important in this disease. And essentially that if there were 2 healthy copies of chromosome 3, that implied that a patient would have a lower risk in the tumor cells from the uveal tumor, that if there were 2 healthy copies of chromosome 3, that it was less likely that a patient would develop metastatic disease later. But if there was 1 copy, or monosomy 3, that it was more likely that the tumor was aggressive and the patient was likely to develop metastatic disease. So isodisomy is an unusual situation where if you just kind of look superficially at the chromosomes, it looks like there are 2 healthy copies. But in fact, what's happened is that 1 copy has been lost and the remaining copy has sort of reduplicated itself. And so it kind of looks superficially like there are 2 copies, but really there's only 1 healthy copy. And so it stands to reason to make sense, right? That's a riskier situation than normal healthy disomy and a higher risk feature. In general, cytogenetics are not as predictive as molecular testing that of the kind that we've been talking about today. And so it's hard to sort of say, okay, how risky is that compared to the GP class or the next, findings on next generation sequencing, but it certainly is kind of a high risk feature. So what I wrote in the chat to this patient is that, I would recommend that a patient who came to me, was treated elsewhere and had that testing, have more frequent surveillance than a patient who had disomy 3, certainly, but it's really, not quite as accurate as what Dr. Williams and I work with every day.
So our next question is from Elisa, and this says, what are the updates on the 1A versus the 1B in regards to risk?
So the class 1A and 1B groups were developed based on the very first prospective validation of the GEP test. That was the COOG-1 study. And based on that cohort, it looked like class 1A and class 1B stratified, separated, with class 1A being low risk, class 1B intermediate risk. What's interesting is the COOG-2 study, which is more recent, much larger, 3 times larger than COOG-1, did not find significant risk stratification between 1A and 1B, at least not at the 5-year mark. And I think one potential reason for that is that COOG-2 and I'd love to hear Dr. Schefler and Dr. Williams' thoughts on this too, but COOG-2 contained many more small tumors than COOG-1 did. So it's a different demographic of patients. And there may be something about subclass, the 1A and 1B groups, that is more important for the larger tumors. So Castle is continuing to report the subclass information on the test report. And my understanding is COOG will continue to follow those groups over time to see if there's any long-term value for 1A and 1B.
So I guess my initial confusion around the 1A, 1B was with the new reporting was that it seemed like the PRAME was a little more important than the differentiation between the 1A, 1B. Can you guys explain why that is? Kat, I love that you said that you're still expanding on following these patients to make sure that you're seeing what happens in the future.
Yeah, I think that's a fantastic question. And I think, Kat, you did a really good job at highlighting this. And so I think initially we were thinking, based on what we saw from COOG-1, that 1A and 1B really stratified and really separated in terms of prognosis, where 1B had a higher risk than 1A. What we realize now with COOG-2 is that there really is not as much of a difference between 1B and 1A. And so we kind of look at class 1 as a group together overall. The COOG group will continue to evaluate that down the road to make sure that's the case. But with a much larger sample, it looks like class 1 kind of stratifies together. In regards to your question about PRAME, PRAME was something that we thought made a difference early on. And Dr. Schefler kind of mentioned the paper in, I think, 2016 or 2017 that kind of highlighted the role and the significance of PRAME in molecular prognostication in terms of the risk of metastasis. What COOG-2 did was evaluate that prospectively to actually assess how much of a difference PRAME made. And so basically we understand that the first most important thing is GEP, looking at class 1 versus class 2. And then once you get that information, PRAME additionally stratifies, so provides additional information on top of class 1 and class 2 to assess risk. And so at this point, GEP class 1 and class 2, followed by PRAME, negative and positive, seems to be the best way to classify these lesions, as opposed to focusing on 1A versus 1B. And I do think that, initially, and Dr. Schefler, you can correct me if I'm wrong, because you were involved in this at a much earlier point than I was. But I think, when you're trying to involve patients in studies and you're doing biopsies, you're using tumors of size that you can feel more comfortable getting enough tissue. And we were doing biopsies on larger tumors. And by the time COOG-2 came around, we were including patients with smaller tumors, feeling more comfortable doing biopsies of those lesions. And with the excellent results that we showed earlier, we know that there's a really, really high rate of getting sufficient samples. And so as a result, in the COOG-2, a much larger range of tumors were included in the study. And I think that's much more representative of what we're seeing on a daily basis with our patients, having a range of both smaller tumors and larger tumors and kind of everything in between.
Yeah, I agree with that. That's absolutely true. The reason why the kind of range of sizes of tumors in COOG-2 was larger than was kind of had a larger range and went down to much smaller tumors than COOG-1 was just because most of the clinicians involved in this work, at that point had many more thousands of patients under their belt, and we're more comfortable surgically biopsying smaller tumors, which are technically more challenging. I would add to that, and this is getting pretty nuanced, and this is related to one of the questions in the chat, that what we've learned over time, in large part because of this work, is that when tumors are very large, one of the things that indicates to us is that they've been there a long time, and they've had a lot of time to grow and mature, and for the misprints in their DNA to be propagated, right? So what we understand better now is that with really large tumors, typically the genetics throughout the tumor tend to be pretty homogeneous. Most of the cells kind of carry the same mutation and express them in the same way. What we understand better now is that with really, really little tumors, which are, you can think of them as like earlier in the evolutionary biology of the disease, there's a little bit more heterogeneity. And there's also can be a situation where we have what are called competing clones, like one little clone that essentially is like class 2 and one little clone that's class 1, and they're competing. And the more aggressive clone will typically win out. In many ways, part of what this study did for us, which has been so groundbreaking, is to help us understand what's happening in the very beginning of the biology, because that's really how we're going to learn to solve the mystery of this disease. And a lot of our understanding of the biology in those early tumors with competing clones and heterogeneity and all the complexity is really still like evolving day by day. Many of the, I think, confusing results we get are in that setting of small tumors, and it's important to kind of talk to your doctor about those subtleties. If you have a result that has what feels like conflicting information between the GP, the PRAME, and the NGS, there are cases where those things don't all line up, and there are reasons for that are often very much at the forefront of what we're understanding about this disease. And so, hopefully each person's clinician can help them understand that.
Can we just generally reiterate what's changed, as of 2025 NCCN guidelines for surveillance? What's changed because of the new reports? And how should somebody who's particularly further out, like say 5-10 years out, how should they be advocating with their care for how, their scans are happening or their surveillance is taking place?
This is a very interesting question, and this is something that we are still discussing quite commonly as a community of ocular oncologists and medical oncologists as well. We kind of understand that there's a bimodal distribution to the way metastasis develops, basically meaning there's a group of patients that are at risk for metastasis early on after diagnosis within the first few years, and then there's a group of patients that may develop metastasis later on, so after 5 years or so. And we do have some understanding of which patients those are from COOG-1, but we are gaining more understanding from that with COOG-2. As we know that COOG-2 is more recent, we have not had these patients get out far enough to fully understand this information yet. And so I think this is a little bit of a personal decision between the patient, the ocular oncologist, the medical oncologist, in terms of how long they follow systemic surveillance. I actually, in our practice, we do something similar to Dr. Schefler's practice, where we do surveillance up to 10 years and then kind of have a little bit more of a nuanced conversation after that. But I think it is it's not something that we understand fully in order to be able to say there's definitive information. As we get further away from the COOG-2, we will have longer follow-up and we'll have more data to really support that decision over time.
With the current data, do medical oncologists, and I'm making the assumption that, as ocular oncologists, you guys are mostly sending your patients out for surveillance to a medical oncologist, especially in like the case of a higher risk patient. But obviously, like, you guys know how the surveillance works as well. I know there's kind of a mix, right, of patients who have been referred to a medical oncologist who specializes in uveal melanoma. And then there's also groups of patients who just don't have access to a doctor like that. And so they continue to be monitored and scanned by their ocular oncologist. Is there anything like right now that patients, who are recently diagnosed or coming up on diagnosis, maybe they're seeing this, 5 months after they got diagnosed, that they should keep in mind from those test results, just to make sure that they're getting scanned as frequently as they need to be? A specific example would be like in the case of a class 2 PRAME negative patient, what's the nuance there? Should they still be seen at the super class 2, every 3 to 4 months, or does the PRAME negative make it 6 months is more okay? Like, how do you guys make the decisions for how to monitor surveillance that way?
I think Kat did a fantastic job in her session talking about the national guidelines, the NCCN guidelines, and those are something that are helpful standards that we use from an imaging standpoint. Where patients with a class 1 PRAME negative lesion, we recommend following on a once a year basis or somewhere around once a year. Class 1 PRAME positive, we look between 6 to 12 months depending, and then class 2, whether or not it's PRAME negative or positive, are considered high risk. And so those patients we usually follow every 3 to 4 months or so. This is something that we are still trying to fine tune as a community as well. And there was a recent Delphi study, or basically a study composed of a number of ocular oncologists, medical oncologists, radiologists as well, and others, kind of looking at what practice patterns are, not only for how often testing should be done, but also for what type of imaging should be used. And so this is something that has been submitted and hopefully will be published soon. And so people will be able to get access to the information about what we agree upon as a group. But there are some nuances in this that we are still trying to figure out.
I would say, in addition to that, that the Delphi study concept that Dr. Williams talked about was basically just like a bunch of people in a room expressing their opinions. And the reason why Delphi studies are done is when there's not good, high quality scientific data. That the answer is really we don't know. There are no prospective clinical trials looking at different screening strategies and which lead to earlier diagnosis of metastatic disease. And then if you have an earlier diagnosis, does that actually lead to longer term survival? Believe it or not, we actually don't know the answer to that. So every center does the long and short is every study center does it differently. It's sort of based on clinician experience and opinion. I think it's hard to sort of point fingers at anyone saying, hey, you should be doing it this way or that way, because we really don't have standards. So we each have our own sort of algorithm. A lot of it is based, sadly, as many things are in American medicine, on what insurance you have, what they'll cover, what you have access to. And so there's a range of strategies that are acceptable. And unfortunately, there really is that there's not a gold standard. And I think the thing worth understanding as a patient also is that the reason why it's hard for us to do prospective trials on this is that these clinical trials cost a lot of money. Doing high quality clinical trials is extraordinarily expensive. And if you think about it, for most of these types of studies, you need a funding agency who has an interest in the outcome, right? So if we're doing screening, right, primarily we're using CAT scans and MRI scans, right? Those companies are not going to pay for this. They don't really particularly care what happens. And, in the past, we got a lot of funding for studies like this from the NIH. A lot of that funding, has gone away. And so it's just logistically and financially a very, very hard thing for our community to make happen and get funded. But that doesn't mean we don't think it's important and we don't wish we could. We just, it's very difficult to make it happen in a really rare cancer.
We have kind of a unique question here. The risk class is determining, like class 1, class 2, that determines the risk of metastasis. And so if you're, say, a class 1 and you end up metastasizing, that does that information, the PRAME negative, PRAME positive, does that stay important in treating your metastatic disease?
So as we've all been discussing this morning, what GEP and PRAME have been studied for is their ability to predict the likelihood that a patient will develop metastatic disease. They have not been studied for this more nuanced, complicated question, which is, okay, how aggressive will the metastatic disease be once it develops? We just don't have that data and don't know. Certainly it seems logical, right? It stands to reason that if the disease is more aggressive, the eye may be more aggressive once it spreads throughout the body. But the truth is, once a cancer is sort of swimming around the whole body, there are many, many factors that affect how it acts, how young is the patient, how strong is their immune system, all sorts of crazy details related to the liver angioanatomy, the blood vessels in the liver. It's just extremely, extremely complicated. And so this testing in the eye is not used and not validated to predict rates of metastatic disease once it's developed. So I wouldn't use it to extrapolate it to gain that type of information.
Agreed.
This is kind of just a historical question. Do you guys have any studies that are happening, any questions that we're trying to answer as far as, is it possible to make a guess as to how long ago a primary and secondary tumor mutation begins? As an example, I guess I'll use myself, class 2 PRAME positive. How likely is it that that's been going on for 2 years, 3 years, 5 years before it was ever diagnosed to my eye?
Yeah, I think this is another question that we don't know the answer to, and I think is very difficult for us to assess. This is something that each patient is going to be a little bit different. And when we look at the tumors, we have seen very, very small tumors that are class 2 PRAME positive. We've seen very, very large tumors that are class 1 PRAME negative. Dr. Schefler showed an example like that. And so, previously, years ago, we would have thought that the very, very large tumors were the ones that were more aggressive, potentially with more metastatic potential, maybe because we were thinking they were growing at a faster rate and were able to achieve a larger size as a result. But as we've done more biopsies on tumors of different sizes and understood their molecular profiles a little bit more, we see that there's a huge range in those. And so it is really difficult for us to make that assessment at the moment.
This question is asking, when you do a biopsy at the time of treating, say, a large tumor, is it possible for the biopsy to test different areas of the tumor? So, the ball, and then can we take a sample from here and a sample from here? Why or why not would that be a good idea?
When these tests were originally developed, tumor heterogeneity, or the idea that the genetics were some of the key genes involved in the development of the tumor and which of those were mutated and then how they were being expressed was going to be variable in different parts of the tumor, was a very hot topic. Like, well, what if you sample one part of the tumor and you get one answer, but if you had sampled another, it would have been another answer. It's become clear over time that the bigger and larger and more mature the tumor is, the more homogeneous the expression of the genes is. And again, as I said before, that kind of makes sense, right? It's been longer, it's been there in theory longer, growing more, and sort of had more time for all the cells to sort of resemble each other. In very small early tumors, there is a little bit more heterogeneity, but by and large, the better and better we've gotten technically and surgically doing these biopsies, the more and more we're getting good at being able to extract very valuable information even from very small tumors, and kind of reliable data even from small tumors. All that being said, it is technically possible to do more than one biopsy from different spots in a tumor at the time, and there's certainly situations where clinicians will do that. So for example, if there's a tumor where one part of it looks very necrotic, meaning like it's almost cut off its own blood supply and it's very dead, but another part that looks very active, sometimes the clinician will say, hey, I'm gonna take tissue from that more active part because it's more likely to be more representative of what's going on now, that kind of thing. But routinely, I would say most ocular oncologists who do these tests will pick one spot and send that off and just assess the answer from that one spot. As Kat mentioned, we do really 3 sort of sets of tests these days on most patients, and all of those sets can be done from that one spot. Personally, in our center, because we bank tissue from every patient, as I mentioned, we actually always do 2 spots, but it isn't exactly for the purpose of the heterogeneity problem. It's because we want tissue for those 2 purposes. So it's kind of a complicated question, but the answer is certainly technically that can be done, and in certain situations that's clinically appropriate.
Thank you, Dr. Schefler. Okay, so this is talking about BAP1 mutation. We've talked a lot about these different genetic mutations and the sequencing test, or the sequencing section of the DecisionX-UM test. Is it possible to learn more about the specific BAP1 mutation that a patient has? And if so, how do they get that information?
I think in particular in relation to this question, once you have a BAP1 mutation, we know that increases the risk. And then looking at gene expression profile, or PRAME, is going to give us kind of the most important information. There's a lot that we're still learning about BAP1 mutations. We're learning which ones are pathogenic and which ones aren't, which ones kind of play a more significant role and which ones don't. And we're also learning that there are some BAP1 mutations that might be harder for us to identify. And so I think this is an area where we still have a lot more to learn. But I think once we know we have a BAP1 mutation, there is an increased risk. And so kind of from that, you can think about, well, going back to GEP and PRAME to really understand your risk profile, and then kind of looking forward, thinking about hereditary disease, et cetera. I think the Castle test itself does come with information about the specific type of BAP1 mutation that's there if you want that information. So it is available, but we're not 100% sure what to do with that yet.
The question says, what % of tumors with BAP1 will show a germline BAP1 mutation?
So it's a great question. Across the world, the thing about these inherited family cancer syndromes is that they run in families and they run in populations, actually. So first off, I would say that it probably varies by region around the world, because what we think happens with these syndromes is that there's probably something called a founder mutation, which is literally that like 5 or 6 or 10 or 15 generations ago in human history, literally someone had this mutation and then it kind of spread throughout a particular population. So it may vary around the world. That being said, the current literature in the United States reflects about a 1 to 3% incidence of this among patients with uveal melanoma. First of all, this is already a rare disease, right? So we're talking about a very, very rare small population within an already rare group of patients. In our center, because we've been doing studies over the last couple of years looking at this, we actually are seeing that percentage be a little higher, more like in the 8 to 9% risk. But either way, it's very low. And so the majority of patients who walk in the door and see us and have uveal melanoma, and even if you have a backbone mutation in your tumor, will not carry this syndrome. But we have broadened in our center the people in whom we test for the germline syndrome because it has such profound implications for both that patient and their family members, as I mentioned before. And it's also worth knowing that there's at least one other inherited syndrome that has been identified that increases patients' risk of developing uveal melanoma, and there are likely to be others. Part of the problem with this is that science is always evolving and we're always discovering more. So 15 years ago, we didn't even know about the BAP1 tumor predisposition syndrome, right? And now we know about this one and at least one other, and there are going to be others. So I take care of a number of families who clearly have an inherited family syndrome in which many people in the pedigree have different cancers, but they come up negative on the BAP1 germline test. And that suggests there's something else that has not yet is just not yet understood. And that's also true across all of cancer medicine. For example, to use a kind of a more common example, breast cancer is very, very common in the US population and around the world. And most patients, test negative for BRCA and these other inherited family cancer syndromes. But there are a good number of families across the world where, like, every woman in the pedigree has breast cancer, but they come up negative on those tests. And that suggests there are just other syndromes that have not yet been identified. So we don't understand all this, and that's important to know.
Yeah, I think, Dr. Scheffler's answer is really important. Number one, I kind of mentioned this when she shared her case. Some of the work that she's done at her center is helping us kind of understand this a little bit more, and I think will help shape a little bit about how we think about this moving forward. And I think a lot of the answers to these questions that we've been kind of giving lately has shown how much we know and how far we've come, but also that there's still a lot more for us to learn. And so, continue asking these questions because that helps push and drive the science. And we will continue to try and do as much as we can to learn more as a community in general. But we definitely still have a long way to go in terms of understanding all of these things.
Really good point. One additional thing that Dr. Williams is saying that just made me think of something that I think is worth adding. On one of Kat's slides, or maybe it's Dr. Williams' slides, it mentioned like the sensitivity and the accuracy of the Castle test and the likelihood that you might get like a negative result. And that likelihood is very, very low, as his slide showed. It's kind of in the 1 to 2% range. But I'm sure that everyone on the Zoom has had, friends they've made in the uveal melanoma community, like on social media, who were told that their tumor was class 1 prime negative and then ended up developing metastatic disease anyway. So a couple of points I think that are important to make about this. One is that, no medical test is 100% accurate. Science and the human body are just too complicated for us to be perfect all the time at everything. And the other thing is that there's a lot of real complexities with this testing. The Castle tests were designed to assess, as we've been saying, the prognostic implications of these mutations, meaning like once you have uveal melanoma, what's the chance that 1 or 2 of those cells got out and are hiding in your liver? They're not designed to assess the surgical skills of the surgeon. So if the surgeon sends a piece of retina to the lab in Arizona, the algorithm of test is actually designed to come back class 1 prime negative. And the reason is that the retina does not express those genes that when mutated, are overexpressed or underexpressed in this tumor. It's like we think of it as healthy, normal tissue. So it doesn't express those things. So that's how it comes back. And so everything comes back to the surgical skills of the clinician and whether the biopsy was done technically in an appropriate and accurate way. Some of these tumors, particularly small ones, the technical skills required to do them are quite complex and require a zillion years of training, just like Dr. Williams and I did it. But even after a zillion years of training, there are cases that are challenging. Some tumors bleed, some eyes, some tumors are more sticky and they really just don't want to be released from their microenvironment and go into the instrument that we use to get them. And also, scarily enough, we actually don't have the ideal instruments developed for these procedures yet. We're doing the best we can with the instruments that have been developed, and our micro instruments are quite good, but they're not perfect yet. Again, we are victims of the fact that this is a rare disease and surgical device manufacturers are not interested in helping us with a disease that only affects 2,000 patients per year. So there are a lot of nuances and complexities. And if you meet a patient online who says, well, I was class 1 prime negative and I got metastatic disease, the test is useless, that's really not true. And there's just a lot of nuances to it. So.
Yeah, absolutely.
Just wanted to put that out there.
And those fears come up a lot for patients, and I'm sure you guys see that
Totally
all the time.
understandably. Totally understandably.
I don't feel like we need to go into some of these fears. We have addressed some of these in previous podcasts and previous discussions with Dr. Schefler and also with Dr. Williams, where if you want to check those out on the YouTube channel or on the I Believe podcast, we do talk about like the why or why not for a biopsy. We talk about kind of the risk, cost, benefit, all of those different things. Overall, though, the information that we're sharing here with COOG2 and with the update kind of to what we know is, like Dr. Williams said, you know, this is so much more than we knew 5-10 years ago. And we have so much more to learn, but we've made some really huge strides. I do want to like just kind of point us in the direction of the future. So one of the things you guys mentioned throughout the presentation was that the information, you know, gleaned from the biopsy can tell a patient if they are potentially eligible for an adjuvant clinical trial. Are there any current adjuvant clinical trials based on the new information that we have and just in the present day as of today, I suppose?
There are some adjuvant clinical trials I know at our center in University of Miami through the work of Jose Letsky, a medical oncologist, and Bill Harbour, who kind of helped start or who started COOG, as Dr. Schefler mentioned. They came up with a trial looking at quizzinostat, which is basically an HDAC inhibitor. And so basically meaning that it is currently enrolling for patients who have high-risk disease. So patients with class 2 disease are potentially eligible to enroll in that clinical trial. So that's at least one trial that's available and is currently enrolling in our center.
I would say, like at any given time, mostly over the last decade, there have been anywhere between 2 and 4 adjuvant trials open across the United States, and then they've opened, they've enrolled, and sadly, they've all turned out to have negative results, which is why we don't have FDA-approved therapy to use in the adjuvant setting. But if you live in a city where there's an adjuvant trial available and you have high-risk genetics, I would definitely encourage you to talk to your ocular oncologist or medical oncologist about it, because certainly it's, you know, a good thing to do, both potentially to help yourself and to help science.
Yeah. And just because they haven't worked in the past doesn't mean that the next one will not work.
Even if a trial doesn't show that it's effective for the entire population of patients, that doesn't mean it might not have helped 1 or 2 or 3 or 5 patients in the trial. I have several patients who were in adjuvant trials 5 to 10 years ago that have subsequently closed and were negative, but those patients are alive and well, and they are convinced that for themselves that those approaches did work, and that very well may be true. And so there's lots of great reasons to try to explore clinical trials if you're eligible.
If anybody has old tissue or is wondering if they have tissue, what's the best way for a patient who is looking for an old report? Maybe they never got their full report, or they want to know if there is a sequencing report. They just want to know what I don't know. I avoided my Castle report for a little while. I heard about it and then I put my head in the sand and I ignored it for like a year. So then I forgot, what did it actually say? So for patients who just want to see it again or who want to know if they could have tissue tested, what's the best way for them to contact Castle and get that information?
You can request a copy of your report by emailing our clinical services team, and you just need to provide your name, date of birth, and the reports that you're looking for. So whether it was the GEP report, PRAME report, sequencing report, or all of the above. And you can also ask them to check if we have residual tissue saved.
Okay, and then a follow-up question to the adjuvant trials. Are those trials usually recommended to be started or enrolled in within a specific time frame after diagnosis? Dr. Williams, do you know maybe like who would be the best person to ask that question to, especially in the case of the quizzinostat? Is that how you say it?
Our medical oncologists are the best ones to talk to about that. So some of it is going to be dependent upon when disease started, how extensive disease, your genetic profile, when you were diagnosed, how far away that was, whether or not you've been enrolled in any other clinical trials. But I can put their information in the chat if that's helpful. But it is based on a clinical trial by clinical trial basis.
I will say broadly for adjuvant trials specifically, the majority of them historically have required that patients enter within 6 months of the time of treatment of the primary tumor. And as Dr. Williams said, there are almost always requirements for the genetics of the tumor, but in terms of the time frame, it tends to be 6 months. Not always, but there is usually a time frame.
And with the idea being that you want to get a person enrolled earlier for the adjuvant therapy to be beneficial.
I feel like we have covered so much today, you guys. So I really want to encourage you, if you've been listening to this live and you want to come back and revisit any portion of this recording, please stay tuned. Make sure to subscribe on the YouTube channel because we will have this up later after it's been edited. But I just want to give a huge shout out to everybody who's participated with the Q&A, to our doctors who have come on and presented and also answered all of these questions throughout the last hour and a half or so. We could not do this without our doctors who are willing to step up to bat, both for their patients in the research center, like in the COOG studies. I think, Dr. Schefler, you shared a picture where it showed like a lot of the doctors who are involved in the COOG study in the collaborative ocular oncology group. And there are so many physicians out there who are just so intent, between medical oncologists and ocular oncologists, who are just trying really hard to work together to bring together the information. And I just want to give you guys a huge thanks from us as a community for collaborating and for working together to just try and find answers and move us forward on the research pendulum, I suppose. What's next? What should we be on the lookout for? What are you guys most excited for COOG? Maybe just give us one little hopeful teaser that we could look forward to.
I think, science is slow. It can often be really frustrating for patients to wait it out for us to, get answers to a lot of these really important questions. I guess I would say, as you were saying tonight, everyone should kind of rest assured that there's a small but strong community of us who are, completely dedicated to this disease and spend all day long trying to improve the diagnostics and prognostics and treatment for this. The COOG two is really like the richest data set we've ever had in this disease, and it's so big and so detailed and has so many patients that it's actually going to take us probably a decade to kind of extract every useful piece of information out of it. So a lot of discoveries are going to come out of that over the next 10 years. And as we continue to follow the patients who were in the study and learn more about what happens to them. And the more we understand the genetics of the disease, the more poised we'll be to come up with effective targeted treatments. So, I would say the best thing as a patient is to ask the ocular oncologists and melanoma medical oncologists who take care of you, kind of what's the latest coming out of COOG2, if that clinician, isn't already sharing that with you spontaneously. And, most busy ocular oncologists will know the answer to that. And kind of also keeping up to date on the newest adjuvant and metastatic disease trials that are coming out. That changes, almost every quarter. And that's a way to kind of stay on top of things. And the other resource I always point patients to is if you go to clinicaltrials.gov, which is a free open website that the National Institute of Health runs, and you put in the little search bar uveal melanoma or metastatic uveal melanoma if you have metastatic disease, that will give you a listing of all of the kind of legitimate registered prospective interventional clinical trials in the United States that are currently open for this disease. And you can actually read about each one. And typically there'll be a contact email or phone number for the coordinator for that study. And that's a good way to educate yourself too.
Yeah, I mean, I think Dr. Scheffler stated it perfectly. I will say that personally, considering how large the data set is for COOG2, there are a number of individual studies or smaller groups that we're all kind of interested in learning more about, and to kind of understand specific situations that might apply to smaller subsets of patients on a kind of a more specific level. And I think that'll be really helpful, really exciting to kind of utilize this large data set, as the first two studies that have come out have really helped to support and validate GEP and PRAME, and then looked at next generation sequencing. I think the additional studies that come out may not have as such broad implications, but they will be extremely helpful and very, very interesting to smaller subsets of patients and smaller types of groups. And there's a number of them that I'm very interested in looking at as well. So I think
Tell us about a couple of those groups, Dr. Williams, because it's actually really fascinating.
Yeah, so I think one for me is looking at patients who have ocular dermal melanocytosis. And so this is where you have increased pigmentation in the white part of the eye, and the sclera, and the iris, and in the back part of the eye too. And that predisposes patients to uveal melanoma. And so kind of understanding what are the molecular characteristics of people with this condition and what does that mean? I think that's something that is really, really interesting and will be helpful for us to understand that a little bit more. Another one that has been discussed is iris tumors. When we talk about uveal melanoma, we are often talking about ciliary body and choroidal lesions because those tend to be the more aggressive ones. And we know that iris tumors tend not to be as aggressive, but we don't really have a great understanding of the molecular profile of those tumors. And I think that's going to be really helpful and interesting to understand that a bit better.
Excellent. You guys, I can't thank you enough for participating, all of you guys in our online audience, as well as our physicians. We're so glad that we can have each of you guys here today on a Saturday morning in the middle of the holiday season. So thank you for taking the time out of your day to just make this possible and bring us this information. I think there was a patient who he mentioned he's 12 or 13 years into diagnosis, but he tries to stay up to date to the new information about uveal melanoma. And I think that's a really, just a really strong self-advocate of a patient to be able to do that and to stay in the know and to want to stay in the know. So kudos to all of you guys who are here live. Share this with a friend or two once it goes off to the YouTube channel.
Thanks so much.
Thanks so much for having us.
And just, again, huge thank you to Kat Castle Biosciences. Dr. Kat Alsina did a fantastic job in compiling all of this information and just making sure that our presentation went as seamlessly as possible. So thank you, huge thank you to Kat for all of your work, and to everybody who showed up and made this possible. We will see you guys next time. Just as a fun reminder, we do have our sponsors who make this webinar and our webinar series possible. Stay tuned for next year because we do have some fantastic topics coming to you in the beginning of 2026. So if you're not already, subscribe to the newsletter. The easiest way that you can do that is to go to our website, www.acureinsight.org, and you're going to hit the top button. There's a little blue button that says join the newsletter. And this is going to be a super easy way for you to stay in the know, get all of the most up-to-date registration for upcoming webinars, our upcoming Eye on Mental Health seminar that's going to take place at the end of January, as well as our in-person patient meeting, which, heads up, it's happening in Dallas, Texas, coming in October of next year. We are so glad that we have so much participation online, but we just would encourage you guys, consider coming out to the inpatient meeting in Dallas next year. Make your plans ahead of time, and we would love to see you there. Check out the YouTube channel, stay in the know, and we will just continue bringing you guys as much content as we can. With that, I'm going to go ahead and say goodbye. You guys have been a fantastic audience, and we look forward to seeing you guys next time.